Here is your
Okay.
Right. So if you have read and understood considering a clinical examination station, kindly please begin.
I will enter the room. I will wash my hands. I will introduce myself. Hello, I'm Dr. Faizan. I'm one of the surgical candidates. May I confirm your name and age, please?
Yes, I'm Smith, 67 years old.
Nice to meet you, Mr. Smith. Today, I've been asked to examine your heart. This will involve me looking, feeling at your chest, and then feeling the pulses in your arms, uh, arm and neck, and then listening to your heart sounds. Is that okay with you?
Yes.
Do you have any pain before we proceed?
Not that much.
Okay. I expose the patient by asking him to remove his shirt or a t-shirt. Then I will make the patient lie down in 45 degrees position on a bed. Then I will start inspection. I will inspect from the end of the bed. I will look for any surrounding walking aids, any medications, any charts, drug charts, any ECG. Then I will start by inspecting the arms. Can you put your arms forward for me? And I
Okay.
will look for the palmar surface. I will look for the any general lesion, lossless nodes, and any xanthomata, and the dorsal surface. I will look for any splinter hemorrhages. And then I will ask the patient, can you put your fingers together like this for me? And I will see for clubbing. Then I will look for any peripheral cyanosis also. Then I will look for also any tar staining. Then I will do the palpation. I will assess the temperature. I will compare both sides. Uh, then I will check the capillary refill time. Then I will palpate the radial pulse.
Yes.
Then I will check the rate of the radial pulse and rhythm. Then I will check for radial delay. Then
Yes.
I will ask the patient if he has any pain in his shoulder. If not, I will elevate the right arm, right shoulder, abduct the right shoulder, and feel for any what this collapsing pulse. Then after that, I will palpate the brachial pulse, and then I will auscultate the carotid artery. If there is no bruit, I will palpate the carotid pulse one by one.
Yes.
Then I will ask the patient to turn the neck to the opposite side and see for any raised GVP, and then I will inspect the mouth. I will ask the patient to open the mouth and look for any central cyanosis and the state of dentition. I will inspect the eyes for any pallor, any xanthomas, uh, and any arcus. Then I will proceed to the chest examination. I will inspect the chest. I will look for any visible scars, any visible apex pulsations. Then I will start palpation. I will place my hand. I will feel for the apex beat. Then I will feel for the fast and heaves with the heel of my hand. Then I will feel for thrills with my fingers of my hand in all the areas. Then so that I will auscultate. I will palpate the carotid pulse simultaneously. I will auscultate the all the areas, first with the diaphragm, then I will also auscultate with the bell of my diaphragm, bell of my stethoscope. Then I will make the patient roll onto the left side. I will also auscultate the axilla, and I will also auscultate the carotid artery. Then I will auscultate the lung bases to see for any pulmonary edema. Then I will also, after this, after auscultation, I will look for any sacral edema and any lower limb edema, and any scars. I will inspect the lower limb for any previous scars for any vein harvest. Then I would also yeah, that completes my examination. If time permits, I will do. I would like to examine the BP, and I would like to do a complete peripheral vascular examination and a respiratory examination.
Okay, and lower limb examination for what do you have to rule out?
DVT.
Edema, yeah, okay, DVT. All right.
Thank you.
And can you quickly tell me what are the areas you'll auscultate for the heart?
Yes,
For all the yes, 4 chambers,
yes,
please.
yes. The right second intercostal space parasternal edge for the pulmonary area, the left second intercostal space parasternal edge for the aortic area, the left fourth intercostal space parasternal edge for the this one tricuspid area, and the left fifth intercostal space for the
Mitral.
mid-clavicular line for the
In mid-clavicular, yes. And this completes your examination. Okay. Can you please summarize your examination?
Yes, I've examined a 67-year-old male patient who's posted for right inguinal hernia repair. On examination, the patient had a scar below the left clavicle.
Yes, and
And on inspection, the patient had a scar below the left clavicle, and there were no signs of any stigmata of any cardiovascular disease peripherally. There was no cyanosis or clubbing. There was no raised here JVP might be raised.
and
The patient there was a raised JVP, and on palpation there was no the apex peak was felt in the left fifth intercostal space, mid-clavicular line. There was no palpable heave. On auscultation, the heart sounds were normal, and the patient did not have any murmurs, and the patient might be having, in this case, basal crepitations.
okay.
And might also have a sacral and a lower limb edema.
What investigations would you ask for this patient preoperatively?
Yes, I will ask for an ECG, blood test. I will ask for a complete blood picture, urea and electrolytes, LFT, ECG, 2D echo.
Yes, echo and blood for
And,
INR because patient might be taking
INR.
a warfarin. And okay, can you tell me how would you manage this patient's anticoagulant preoperatively?
Yes. Yes. Preoperatively, I will stop warfarin 5 days before surgery,
Yes.
and I will start a low molecular weight heparin, which can be continued up to 12 to 18 hours before surgery. Then post surgery, I will again start low molecular weight heparin 6 hours post surgery, and then also start warfarin as soon as the patient can take oral fluids. Then I will when the INR is in the range again, I will stop low molecular weight heparin and continue warfarin.
Who would you inform about the pacemaker?
Regarding
Ideally,
the pacemaker,
yes.
I will get the pacemaker checkup done and take advice from the pacemaker clinic. Then I will inform the OT
Okay.
anesthetist, the operating surgeon, and the
Yes.
consultant.
Okay, what precautions
And
must be taken, keeping the pacemaker in mind?
yes, intraoperatively, the monopolar cautery should be avoided. And if at all it is used, then the cautery pad should be placed away from the pacemaker so that it doesn't come in the pacemaker field. And uh, also facilities for temporary pacing and cardiopulmonary resuscitation should be available. And a cardiologist should be available on standby if needed.
All right. Why keeping anticoagulant for this particular patient is very important? Keeping in your mind. What might be the risks if you are not careful with the anticoagulants post-operatively?
There might be thromboembolism.
Yeah, or infective endocarditis. Okay. If you'll do the ECG of this of this patient, what do you expect to see? Can you identify these red circle, please?
Yes,
Oh,
these
sorry.
are the
What is it
no problem.
signifying? Okay, can you read the ECG
These
for me, please?
Yes, uh, this this ECG shows absence of P waves with
Okay.
spike waves,
Yes.
which are suggestive of pacemaker rhythm.
Yes. What else would you comment on the rhythm of the ECG? ECG waveform. It's how would you comment on it?
The rate,
Or I'm just asking the ECG waveform because of the pacemaker. How would you comment on it? Is it what does it signify? The rate? Is it bradycardia? Is it normal? It's what do you see?
the rate looks normal, ma'am.
Yes. Any other significance? If there is any cardiomyopathy or if there is any other condition of the heart that can be evaluated or assessed from just the ECG? And what about the QT interval? Is it normal? Can you comment on it, please?
It is decreased in this. I can't really make out the.
Okay, we'll get back to that later.
It
What
looks
about what
decreased.
you say about the nodal situation or condition of the patient? Since a patient has pacemaker, so waves are not
Yes,
generated by
the patient.
node. So
Yes, so the heart rate will be lower.
yes, towards the bradycardia. Yes.
And I don't know, ma'am, about this.
Yes.
Heart rate will be lower.
Yes. Could there be a symptomatic nodal disease or condition?
Yes, there could be a synodal symptomatic or AV nodal disease.
Yes, very good. So these are the small things in a nutshell that you have to keep in your mind while looking at the ECG of the patient with pacemaker. All right. Yes. Yes, about your examination. Good. It was good. Covered within given time. Just a small thing I was thinking that you did measure the blood pressure of the patient, right?
I told that I would like to measure
Okay.
time permits.
One important thing which you maybe missed in examination, no, in inspection, was any oxygen. Would the patient be presented with the oxygen or not? Since it's
Yes, yes, heart
but
failure.
it's
Yes, patient might.
could be, yes. So oxygen is something you have to look for. All the other things that you were telling, you've already mentioned, so it was very nicely covered. But when you were mentioning the, yes, you didn't talk about the scar that you mentioned in examination later on. Anyway, that was covered. Good. Thank you.